Hello, everyone, and welcome to today's webinar, Consensus Statement Early Effective Initiation for Mothers with Risk Factors with Dr. Jessica Brumley, CNM, PhD. Before we get started, I would like to go over a few items so you know how to participate in today's event. By default, you have joined the presentation listening using your computer's speaker system. If you prefer to join over the telephone, just select the phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of today's presentation. There are also handouts available. Please be sure to download this before the end of the live event. The handouts are located in your panel. Today's webinar will be recorded and available at Medill University and Medill's Education for Lactation Professionals YouTube channel. I would now like to introduce Jessica Brumley, CNM, PhD. Jessica Brumley has been a midwife for 20 years. She is the director of the Division of Midwifery at the University of South Florida in Tampa, Florida. In this role, she has helped to grow a full-scope midwifery service that is an integral part of clinical care, education, and research within the College of Medicine Department of OB/GYN. The USF midwives partner with Tampa General Hospital to advocate for care practices, tools, and policies that support family-centered physiological birth. With no Florida-based midwifery education programs, the USF midwives serve as a large clinical placement site for midwifery students in addition to working with USF learners. Understanding the importance of midwives working within a well-integrated system to provide safe birth outcomes, Dr. Brumley coordinates outreach to community-based midwives to facilitate smooth, safe transfers when indicated. She has partnered with the Florida Perinatal Quality Collaborative to develop and implement labor support training throughout the state with a focus on reducing the low-risk cesarean section rate. She has been an active leader in the American College of Nurse Midwives for many years and has served as Tampa Chapter Chair, Florida President, and current FACNM Board of Directors President-elect. In everything she does, Jessica strives to strengthen, grow, and diversify the midwifery profession. Dr. Brumley?
Thank you. Thank you so much. I guess I should have included some of my lactation credentials in my bio. I've also published in the space of human milk and lactation, including some work around risk factors for delayed lactogenesis, as it was called at the time, and the impact of group prenatal care on breastfeeding outcomes. And I'm really passionate about the work that we do around human milk and lactation. I want to thank everyone for joining us today to talk about early effective lactation initiation, in specific for individuals with risk factors, which I think when you work in a hospital, it's most of those that we care for. All right, our objectives today are to describe the critical window of time to optimize human milk supply, identify factors that are associated with suboptimal milk supply, and describe a clinical pathway to support individuals at risk for suboptimal milk supply. We convened a group of international midwives, and this group was led by a PhD prepared nurse scientist in human milk and lactation. And this group helped to identify the most significant risk factors that can disrupt normal physiologic lactation. The goals of this group and this work is to provide professionals with the resources to ensure that mothers achieve timely and effective secretory activation, that mothers can build a milk supply as robust and feasible for their personal situation or conditions, that more infants receive more human milk, and that more families can achieve their personal breastfeeding goals. So right now, what exists in the current literature is guidance for the healthy newborn that has experienced a normal physiologic birth, a normal healthy pregnancy, labor, and birth, really. And so, you know, there are guidelines for what care should look like for that individual. And then there are also guidelines on how to provide care for vulnerable infants. So, you know, the preterm infant, the infant born with, you know, with requiring critical care, requiring a NICU stay. There are published recommendations for both of those groups of families. But what we don't see are guidelines for everyone else. And I don't know about you, but everyone else is most of what I see in my clinical practice. And so I think it's important for us to know what the science is around caring for individuals with risk factors and how to optimize their health outcomes. And I think you'll see when I go over these risk factors that it really is a broad population. Risk factors impacting normal physiology of milk production include age above 35. I would say every day in my clinical practice, I say 40 is the new 30, and people are delaying childbearing more and more often. And this number is 30 if they're primipares. Age below 20. And so we are seeing fewer teen pregnancies, but that is also a risk factor. Just being primiparous, right? It being your first baby, having a body mass index above 30 or excessive gestational weight gain. This is an area that I've looked at pretty extensively, and what we know is that the body mass index rates or numbers in the United States and worldwide are increasing, and so it is much more common for us to have clients who start their pregnancy with a BMI of 30 or above. And because of that, we find that individuals are also more likely to gain excessively. What has been found in the literature is that the people often follow the weight gain recommendations for someone who has a normal body mass index, so 25 to 35 pounds is what people will often gain, when that's not the recommendation for individuals with a BMI of 30 or higher. They have lower recommendations. We also see that endocrine disorders such as diabetes or gestational diabetes, history of polycystic ovarian syndrome can impact normal physiology, untreated thyroid disorders, right? So all of these like endocrine disorders. If an individual has glandular hypoplasia or insufficient glandular breast tissue, or a history of breast surgery, or exposure to chemotherapy or radiation, that can also impact the normal physiology of milk production. And there is some evidence as well that shows that people who required assistance with conception, particularly in the form of in vitro fertilization, that can impact the normal physiology of milk production. And I would say that for most of the people that I'm caring for, they don't just have one of these risk factors. They typically have multiple risk factors. When you have somebody with a BMI over 30, they're more likely to have diabetes or gestational diabetes. When someone's over 35, they're more likely to have a BMI over 30. Right? So you can see kind of, how they're all interrelated. There are also birth and neonatal related risk factors for inadequate milk production. And some of this can lead back to some of the risk factors that we've already mentioned. If someone's over 35, then they might be more likely to have a preterm birth and a low birth weight baby. Also, we know that many of the complications or factors that we mentioned earlier can lead to someone needing to have their labor induced, and a very stressful or prolonged labor and birth can impact milk production, as well as having an unscheduled cesarean section. A postpartum hemorrhage, right, can be a consequence of a very long labor and birth. So that can impact milk production. All of these factors can also lead to a delay in the first breastfeeding episode. And we know that that can impact milk production. If an individual is breastfeeding or pumping less than 8 times in 24 hours, that can impact milk. If they're needing formula supplementation within the first 48 hours, and if there's a separation of the dyad at birth. I think it's easy to see how so many of these can be interrelated. For example, you have a low birth weight baby, maybe they have a hard time with temperature regulation and they end up in the NICU, therefore being separated from the mom, maybe develop some hypoglycemia and need some kind of, supplementation, in that first day. Maybe the mom has a postpartum hemorrhage and she's not stable, or not requiring critical attention, which may lead to not being able to breastfeed in a timely fashion, or not having the energy or the time to be able to pump an adequate number of times in that first day. I think it's really easy to see how so many of these factors can be interconnected, but also how common they are. So a little about secretory activation or secretory activation. This is the process by which milk synthesis increases after birth. It's triggered by a fall in serum progesterone during the first 2 days postpartum. Timely secretory activation occurs in the first 2 or 3 days, and it is really critical to establishing an adequate milk supply. A delay in this, when it happens at greater than 72 hours postpartum, is associated with early cessation of breastfeeding. So often we hear people saying, I just didn't make enough milk. And then there's a lack of confidence in the process, or sometimes they actually were not making enough milk. It was delayed, possibly because of some of these clinical scenarios that we've already talked about. Secretory activation needs to occur so that the mother can come to volume, which itself is regarded as a milk production volume of greater than or equal to 500 mLs a day by day 14 postpartum. Ignoring recognized risk factors could lead to unnecessary formula supplementation of the infant, thus further negatively impacting the immediate establishment of an adequate milk supply. So really making sure that we're addressing an individual's milk production needs in the early days is critical to her feeling like she makes enough milk and her actually making enough milk. So what is this critical window? Early on in my career, a lot of effort and energy was placed in skin to skin in the first hour, and getting the baby to breast in that first hour, because we know it's the golden hour, and we know that it's such an important part of that immediate sort of postpartum healing and connection with the baby. But it seems like that first hour was made to feel so critical at the exclusion sort of the rest of that time. And so what we know is that window, that critical window, is actually a little larger than just that golden hour. Mammary gland development and function is driven by endocrine and autocrine control factors, with each one of these mechanisms having a different weight depending on the stage of lactation. So we know that during pregnancy, our mammary glands begin to secrete milk at approximately 20 weeks, right? I often cite this when working with patients prenatally. How do I know if I'm going to make enough milk or if I'm going to make milk? And usually at that point, I'm telling them, you're making milk, right? It's already in there. If your baby was born today, you would make milk for a 24-week baby. But it's not, right? We're not releasing it, right? Because of the overriding endocrine status of pregnancy. And that's preventing the development of a robust milk supply during the pregnancy. Following labor and delivery, endocrine factors, including a sharp drop in progesterone levels and the rise of prolactin, cortisol, and insulin levels, enable secretory activation, resulting in the onset of copious milk secretion. Human milk biomarker research shows that the first 5 days are critical for effective initiation of lactation, timely secretory activation, coming to volume, and therefore for subsequent long-term lactation outcomes. So we really have this basically week to impact someone's long-term lactation success. How are we going to use this time? And how are we going to use this time for individuals with risk factors for a delay in secretory activation and coming to volume? Vulnerabilities manifest as risk factors and have their origins in one or a combination of 3 areas. So there's preglandular, related to suboptimal hormonal or endocrine environment. Glandular, related to the function and performance of the glandular tissue. And then postglandular, and that's related to ineffective milk removal. This is an area that's largely overlooked despite its critical importance and the fact that it represents one of the more modifiable lactation management opportunities. There's not too much we can do about giving someone more glands, right? But we do have tools in order to optimize milk removal. So what we know now from this science is that the first week is critical. And what happens in this first week can make the difference in someone having not enough milk long-term or a copious milk supply and confidence in their milk production. So there are a couple different ways that individuals may present. There may be mothers with risk factors for delayed secretory activation and decreased milk production. We've reviewed what those risk factors are. There are mothers who are likely to have a compromised milk supply. And then there are individuals who do not, infants who do not feed effectively at the breast. So we can sort of talk about these separately. And obviously, the ideal state is baby at the breast and plenty of milk, right? Plenty of milk, milk in the fridge, milk in the freezer, milk leaking from our breasts. Like, that's that's what we want for everyone who wants that, and know that physiologically that's going to be optimal. How do we help make that happen? When there's a poor suck or inadequate emptying, what do we do? What we know is that hand expression does not provide the vacuum that a healthy term infant would in order to effectively stimulate the prolactin response. I often will hear patients say, I use the pump, but nothing's coming out. And then we show them how to hand express that thick, rich colostrum, right? Just often comes out better with that hand expression. But when used alone, hand expression has been shown to yield significantly less daily milk volumes than electric pumping. And hospital grade pumps with initiation technology increases supply. And pumping early and pumping often increases supply. So pumping combined with hand expression will provide the much needed colostrum removal in the early stages, but will also provide the appropriate breast stimulation for future milk production and prolactin stimulation. And so it's important for us to understand all of the tools that we have available to feed the baby now and feed the baby in the future. The key risk factors that prevent mothers from achieving a minimum daily milk volume of 500 mLs by day 14 or coming to volume include a BMI over 30, excessive gestational weight gain, diabetes, infertility using assisted reproductive technology, PCOS, that stressful long labor, postpartum hemorrhage, and unscheduled C-section, right? So some of those factors that, that we talked about earlier. And as I mentioned, these are common and these are frequently seen. Many of them, actually, I'll go back. You can see are things that we can identify prenatally, right? So we know prenatally what someone's pre-pregnancy body mass index or how they're gaining. We know prenatally their state of diabetes if they, used IVF for pregnancy, if they have a history of PCOS. And so those are factors that we can identify prenatally in order to help to provide education and support before labor and birth occurs. And so we need to identify or create a plan on how we will educate and support this family. So we should identify and assess risk factors prenatally, provide prenatal breastfeeding education, and engage in discussion around perinatal operational plans for breastfeeding. What is breastfeeding support going to look like for this individual? And there must be an understanding of the impact of these risk factors on timely secretory activation and subsequent lactation performance and coming to volume. And so it's a lot easier to ask someone to pump 8 times in the first 24 hours when this conversation has been had prenatally about what their risk factors are, when the value of human milk and lactation is discussed, and an individual's breastfeeding intentions are assessed ahead of time. So this is a clinical pathway that we worked on for mothers with risk factors for delayed secretory activation and decreased milk production, and or for mothers of infants who have risk factors for feeding issues. And so the first step will always be to assess, is the infant feeding effectively? And you can see in the key that that we've created some, we've listed out some of the ways that this can be assessed, considering both frequency and duration of feeding sessions, their stool output, their urine output, always giving into consideration the infant's weight relative to IV fluids that they may have received during labor and birth, the visual appearance and activity of the infant before and after feeding sessions, right? Do they appear satisfied, and the appearance of nipple and breast tissue before and after feeds. And so in the first 0 to 3 hours of life, if the infant is not feeding effectively, then we need to ensure skin-to-skin contact of mother and infant. We need to assist with positioning and attachment, right? Give them support to help them find that optimal position. Assist with hand expression of colostrum to facilitate direct breastfeeding, and feed any expressed colostrum to the infant. And and this can be done sort of directly at the breast as they lick it up, or with a spoon, right, that we, spoon feed the infant at that time. And then we need to monitor infant feeding effectiveness. If they are feeding effectively, then we just ensure skin-to-skin contact, encourage responsive, breastfeeding, and assess breastfeeding sessions for effectiveness, right? So just that continual assessment. And then after the first, 3 hours of life, if they're not feeding effectively, then we're going to do all of those, all of those things that we mentioned before. But now, if there's no effective feed after assistance, then we should be instructing the mother to express with a double electric hospital grade breast pump using initiation technology until the milk comes in. We should consider if supplementation would be required, and obviously encourage pasteurized donor human milk if supplementation is warranted. And then again, continue to assess at every breastfeeding session. And one of the things I always talk to my clients about is that, if you're supplementing, you're pumping, right? If your baby needs more, then that means that your brain needs the message to make more, and it's only a pump that's going to be able to provide that stimulation. Okay. Oh, I forgot I made it look pretty enlarged to go along the way. There we go. Okay. All right. Mothers who are likely to have a compromised milk supply. So those individuals with glandular hypoplasia or a history of breast surgery, or exposure to chemotherapy or radiation. These are individuals who are much more likely to not be able to come to that full volume, as defined by the 500 mLs or greater in the first 14 days. And so a prenatal plan is really critical, especially for these individuals. And they absolutely should be encouraged to breastfeed, but they also need to have a supplementation plan in place. It's important to know that for some mothers with these conditions, a robust milk supply may never be achievable. And so having a comprehensive breastfeeding plan really should be emphasized, and make sure that this plan is available at the birthing facility. And remember that the benefits of breastfeeding and human milk are dose respondent. And so we should still be encouraging the mother that the largest milk supply that she can achieve is the goal. A low supply in this situation is not a breastfeeding failure. Any breast milk provides immune factors and additional brain development. And so what is the clinical pathway for mothers who are likely to have a compromised milk supply? In that 0 to 3 hours, if the infant is not feeding effectively, then we will do all of the things that we've mentioned before: skin-to-skin contact, make sure we're positioning, assist with hand expression of the colostrum, observe for the effectiveness of direct breastfeeding session. Because mother has a known history that could impact the ability to achieve a complete milk supply, start pumping after each breastfeeding attempt with a double electric pump with initiation technology. So basically, start the pumping right away. If there is an effective latch, then we'll continue to support them in all of the basic ways that we've mentioned before. And then at 3 hours of life, continue to ensure skin-to-skin contact, positioning, and making sure that we're pumping after each feeding attempt using that initiation technology until the milk comes in. And at this point, we should be considering the need for supplementation, given this individual's likelihood for a compromised milk supply. So many ways that we can support individuals either at risk for or likely of having a difficulty coming to volume. Skin to skin is a huge part of that, and supporting them in skin to skin beyond that first hour is an important recommendation. I often have to remind them, right? It's not just when we're breastfeeding. We can do this in between feeds, right? Anytime that you're awake and alert, then you can cuddle with your baby, in this way, making sure that they're getting all the support that they need to learn how to effectively and comfortably latch the baby at the breast, and using the time and resources that we have to teach them this while we're with them. And then setting them up with a breast pump, setting them up with that pump, instructing them on what to expect in these early days, how to use the pump, the importance of initiation technology, and what to expect with their milk volume. I love this picture of the change in the color and the volume of the milk over time, and preparing them with that information. Oh, and I forgot the hand, right? Hand expression of that colostrum in the early days. The first 2 to 3 days of life are critical to establishing an adequate milk supply. And risk factors for delayed secretory activation are prevalent, including but not limited to diabetes, excessive gestational weight gain, obesity, unscheduled cesarean section, and hemorrhage. It's really, I think, a call to action that we're trying to put out. Individuals with risk factors require a proactive approach to optimize milk production. If we wait and see if if secretory activation is delayed in these individuals, we run the risk of them never achieving an adequate milk supply or coming to volume to their full capacity. I want to thank you for your attention, and we have all of these references included in your slide set and in a manuscript that will be coming soon. It's really been a privilege and an honor to review the state of the science for what is, I think, the majority of the individuals that we are caring for, and am happy to answer any questions.
Great. Thank you, Dr. Brumley. Let's see what questions we have. The first question is, so they recommend pumping 8 times in the first 24 hours as well as breastfeeding?
That is accurate. So if the baby is not latching well, then the suction is and that stimulation and that message is not happening. And so if you are if you have assessed that there is not an adequate latch, then we need to keep working at the latch, but we also need to have the pumping session in addition to the latch session. And then if an individual is known to not likely be able to come to full milk volume, they need all the extra stimulation, right, they can get to really optimize their milk production. And so yes, that is the recommendation.
Perfect, thank you. The next question, is it better to use spoon feeding rather than syringe feeding when giving the expressed colostrum?
That's a great question. Honestly, I'm not sure if there is science or evidence on that, and so I can't really speak to if I know that for sure.
Okay. Why is 500, I believe that's milliliters, the threshold for pumping output by 14 days?
It's what's been shown to be the amount required to nourish babies on average. they've looked at sort of populations and their volume of milk.
Okay.
Mm-hmm.
This next question, it says question about maternal preeclampsia and milk supply,
Mm-hmm.
but there's no more after that. Sorry.
Okay.
I guess that's a general
Yeah.
question.
Yeah, so individuals with preeclampsia can absolutely have issues with milk supply, and likely that's related to so many of the other factors that we've already mentioned. So individuals with preeclampsia often are at risk for postpartum hemorrhage, having a long induction, increased risk of cesarean section, being separated from their baby. And so, these are all just so common that they all just kind of run together. And in some of these studies, it can be hard to tease out and to control for some of those factors.
Okay, thank you.
Mm-hmm.
Could it be hand expressing the first 24 hours? It's difficult to use the pump after cesarean, etc., in the first hours.
There's actually been some work that has shown that it can be done quite effectively, and with support, even in the recovery room immediately after cesarean section. And so there is some work that's been published in that space as well. The hand expression just will not create the suction that the body needs in order to be able to have the prolactin level changes that we need to help to message the brain to make the milk.
Perfect.
Mm-hmm.
And keep sending in your questions. I still have more though.
Mm-hmm.
Is there a current scoring system to put these mothers in a high med low risk category like lactation acuity?
Yeah, I am not familiar with one. This is really like, so far as we know, the first time that that this work is being published and done. And if we have any doctoral students out there that are looking for a project to work on, I think this would be a great one to focus on.
Awesome. For mothers with history of breast surgery, no
Mhm.
matter incision location, should be pumping in addition to latching after each feeding?
It does matter. And oftentimes, the individual has been told by their surgeon that milk supply is likely to be impacted. And so these are typically individuals who had breast reduction surgery. And so, glandular tissue may have been removed, or, had an augmentation that might potentially impact supply. So these are just questions we've got to ask. Yeah.
Okay.
Mhm.
Is maternal age, oh, sorry, it shifted, forgive me. Is maternal age an independent risk factor or only when associated with other risk factors?
It's been shown to be an independent risk factor.
Okay.
Mhm.
Does it help if mother pumps prior to the birth, like from 38 weeks plus, to get a start on her breast milk supply? If she does it, can that milk be fed to the baby?
Um, yes and yes. I say that tentatively. There is early science in that space, right? So what we're talking about is antenatal milk expression, and we know that informally people have been doing this for quite some time, and there is some work that was done looking at antenatal milk expression for individuals with diabetes in pregnancy, knowing that these infants may have hypoglycemia and may need to have supplementation. And so there is some work that was done in that space that milk can absolutely be saved and brought to the hospital to be given to the baby if they need to be supplemented, which is great because then you don't need donor human milk or formula supplementation. But also that if the baby needs to be supplemented, then the milk the breast still needs to be stimulated in that moment. So it's like yes and yes, and we need all of the sort of all of the things.
Perfect. Still more questions. Hope you're up for
Mhm.
this.
Yeah.
Is there anything you can do to make up for that lack of skin to skin? How can you help with a baby that gets tired from sucking and falls asleep while feeding?
Oh, so hard, right? I mean, I think that we can use things like supplemental nursing systems, right, to make it a little easier for them, so that they're still skin to skin, but they're but they're not sucking as hard when they're weaker and smaller, and they have some of those risk factors. Sometimes they need to be supplemented or separated from mom, and that's where, again, if they're not sucking at the breast and the breast isn't getting that stimulation, the milk is a good, an important adjunct. I'm sorry, the pump is an important adjunct to that baby that can't really latch well and is tired and weak.
Okay. What about the maternal steroids or maternal blood pressure meds given to mom that affect the milk supply?
Yes. So the studies that looked at that could not identify if um, the risk of inadequate milk supply was related to the steroids, or was related to the subsequent preterm birth that often happen because of the steroids. And so the science wasn't quite strong enough for me to be able to support including that as a risk factor in this current work.
Okay. What about babies with torticollis or tongue tie? Should those mothers pump right away?
So usually you're still needing to assess the latch, right? So even with babies that are tongue-tied, we can sometimes they can figure it out, right? Sometimes they can get on the breast and figure it out. And so I think what's really important is to assess the positioning and the latch and the effectiveness of the feed at each feeding session. And if it seems like they are not effectively latching, you don't stop trying to get them to latch. You keep doing that work, but you pump afterwards to make sure that the suction event is occurring.
Great. Do you know what percentage of women with breast implants experience supply issues?
I'm sorry, I don't know that off the top of my head.
Okay. What are your thoughts on this scenario? High risk mother is pumping, but does not see milk output in the first few days. How many minutes do you recommend pumping for in the presence of no milk output? And is inflammation leading to engorgement a concern?
Oh, I'm always wondering, kind of like what's happening in that moment. Should we try hand expressing before pumping to kind of like get some of that milk out, and kind of give her that boost in like confidence that there is some milk in there. But I will say, I always defer to the IBCLCs in that situation.
Okay,
Yeah.
uh, bear with me here.
Mhm.
What are the recommendations for antenatal milk expression? Can women use a hand pump?
Oh, so I mean, there aren't really current recommendations for antenatal milk expression, and what has been done in individuals who are near term, because there can be some uterine contractions that are stimulated by nipple stimulation. So we wait till they're near term, and yes, they can absolutely use a hand pump, right? This is like it's like bonus milk as far as I'm concerned. It's just like trying to get a little extra in case there needs to be some supplementation in the early days.
Okay. Is there a study that shows how to consider perinatal IV fluids when weight loss appears to be too great, but it is suspected to be partially due to the large amounts of IVF?
Um, I'm sorry, I don't know the answer to that, but I do know that there are some calculations that are sort of like general rules of thumb that people will follow when they know that they've gotten more IV fluids during the labor process. And I don't know them off the top of my head.
Okay, fair enough. 3 hours seems really to start. Oh, I wonder if she means early. 3 hours seems really to start pumping, even if there are no good feeds yet. Can you talk about that research?
So I'm assuming she means 3 hours is early to start pumping, even if there were no good feeds yet. And I would say that that is true in somebody who has a normal physiologic labor and birth and has no risk factors for delayed secretory activation. And so in that individual, right, if I'm like 25 years old and going into spontaneous labor and have an 8-hour labor and a smooth vaginal delivery without an hemorrhage and without diabetes, and my baby doesn't have a very good feeding at the first feeding, I'm probably not worried about that, right? Because it'll catch up, and we're just going to keep working on it. Do lots of skin to skin and try again. But in the population that we're talking about, we're saying it's not too early. That being proactive is really what we need to do in order to help optimize their milk supply.
Okay. Uh, Give me just a second. Would you advocate using double pump with hand expression at 37 weeks antenatally, or only hand expression?
Oh, uh, hand expression just seems like a lot of work at that point. I think you could go either way.
Okay. What advice do you give when we put mom on a pump immediately after birth and mom is discouraged because she is not seeing milk or very little?
I think it's really important for us to help her understand why we're doing this, and that we don't expect to see very much in this pump, but that just the action of that suction is an important action to send the message to help to create the milk volume. And just like we educate people around, what sort of volumes to expect in the early days, and we have like the little belly balls, and that show them how big the baby's belly is, and really and really kind of help them understand that physiology of human milk in this very early time. um, and I think that that can go a long way.
Okay. In case that we use breast pump to express the colostrum the first days to preserve this suction stimulation is very hard to collect the colostrum in the breast pump, and maybe we shouldn't be able to use it. In this case, still being preferred to use breast pump than hand expression.
Yes, right. Because we have to remember that the point of the pumping isn't to collect the colostrum. That's great. And if we get colostrum and can we use it? Yes, absolutely. But the point of the pumping is to stimulate secretory activation so that the milk comes in a timely fashion. And so we may need to do hand expression in order to collect the colostrum, or that this vulnerable infant, right, this infant who's at risk, may need to be supplemented with donated human milk, or formula. But it's in order to ensure the long-term supply of milk to this baby.
Okay. Is there a risk of preterm labor with antepartum pumping?
In theory. And so, I mean, because we know we have protocols around induction of labor with nipple stimulation through the use of a pump, which is why the studies that have looked at antenatal milk expression have done so in people who were full term already.
Okay. What metrics or indicators are useful in evaluating the effectiveness of interventions clinicians use in the hospital which support improving milk production in these at-risk mothers?
Yeah, it's going to be, milk volume and the ways that we assess milk volume, in all the ways, right? Like pre and post feed weights and, total volume in 24 hours are the typical metrics, but also just assessment of satisfaction, of the infant after feeds and maternal confidence of her, of her volume and her breastfeeding, I don't know, self-efficacy, at that point.
Okay. How does immediate postpartum experience influence the breastfeeding initiation process in mothers with risk factors?
I think the way that experience impacts so many of the, of the risk factors that we've mentioned. I don't know, I think a little bit of a vague question, but I would think things like if you have supportive individuals with you, then you're more likely to feel supported in your breastfeeding. If you have the supplies that you need, then that's gonna make you more likely to be able to do the things that you need to do. If you have the supportive professionals to give you education, then you're going to feel more confident and in the process. And so all of those, I think, are critical resources and part of our breastfeeding experience in that early postpartum time.
Perfect. We have just a few more and still just a few minutes if you're okay to keep going.
Yeah.
Awesome. You spoke about identifying and assessing risk factors prenatally, but
Mhm.
what screening tools are used in the hospital while mom is in labor? And what interventions are labor and delivery nurses teaching their at-risk patients or should be teaching?
I think it depends, right? I mean, if somebody's in active labor and unmedicated, this is probably not an opportunity for us to have an educational intervention related to human milk and lactation. There's probably just a lot of support around, around pain management and coping in labor at that time. If somebody's maybe early in an induction process, or comfortable with an epidural, then those are good times to have conversations around what to expect with breastfeeding, and the education can be provided and at that time as well.
Okay. For a lot of mothers, they say they want to do both formula and breast milk. If baby latches well, but parents are still supplementing after, should you have those mothers still pump after?
I think it really has to do with their intentions. When somebody says, I want to do both, then that to me is warranted a further conversation. Can you tell me about, sort of your long-term breastfeeding plans? Can you tell me about why it is that you want to do both so that I can help support you with your plans and your intentions. And so some people say both, and really it's just like I just want to give a little bit of milk and I'm okay because pretty quickly I'm going to go to formula and return to work early. And other times people are saying both because they think that's the right thing to say. They think that I have patients who come from other countries and they think that in the US, people give formula. And so they think that's the right thing to say, or they're worried they're not going to make enough milk, right? So it really takes, I think, more of a conversation and a dialogue to get to what are their goals. And if their goals are to breastfeed long term, if their goals are to mostly breastfeed, then yeah, we should treat them with these recommendations.
Okay. I think we have time for two more. While at-risk mothers experience challenges with early breastfeeding initiation, what added cultural factors would also influence and or halt their efforts with early breastfeeding?
I mean, I think we've talked about some of them, right? Like, so, this sort of like thought that they're supposed to formula feed. I've encountered that. There's some people who think that in some cultures, they think that early milk is bad, or that the baby should be cared for, by someone else, maybe separated from the mom for a period of time. So, I mean, really, we need to just be in tune to what it is that the individuals are sharing with us, and have conversations with them um, that they lead, right? So sort of like approaching care with cultural humility. So not making any assumptions about what people want or know, and ask lots of questions, and then let them help inform how the care plan will be impacted.
Okay, and I kind of feel like that's a good wrap up. Do you have any final comments before we end?
I'm just so thrilled that we had 265 people interested in this topic, and thankful for everyone's attention and energy.
Wonderful. I don't know what that beep was, but you're getting many compliments and many thank yous in the questions pane as well. And so I think this is a good place for us to end. So thank you, Dr. Brumley. Thank you everyone for attending today's webinar, Consensus Statement, Early Effective Initiation for Mothers with Risk Factors. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You'll also receive a follow-up email within 3 days with a link to the survey if you're unable to complete it now. On behalf of Medela Education and our presenter, thank you for joining us today and have a great rest of your day. Thank you again, Dr. Brumley.
Have a great day.
You as well.